I would like then to really welcome our speaker for today. Dr. Kitchlu has been really wonderful to communicate with, and he has really put himself out to come here, so we really do appreciate it, Dr. Kitchlu. Myeloma in the kidney. 14 years ago, my family doctor noticed that I had a problem with my kidneys. In fact, it was such a big problem that he said, you better get to Emerge. And so I went to Emerge, and they diagnosed myeloma. So it was thanks to the kidney problem that immediately I was diagnosed with myeloma. And fortunately, a nephrologist, that's what kidney specialists are, took care of me, and I don't have a kidney problem anymore. I really appreciate what has gone into to the work, what nephrologists have done. That's actually when I found out what nephrologist was. I never heard the word before. So Dr. Kitchlu is a staff nephrologist and director of onconephrology at University Health Network, an assistant professor in the Department of Medicine at the University of Toronto. He completed medical school at Western University, followed by postgraduate training in internal medicine and nephrology at the University of Toronto. He then completed a master's in clinical epidemiology at the University of Toronto as a Phillipson Scholar in the Clinician Scientist Training Program. Dr. Kitchlu's clinical interests and research are centered around onconephrology with specific focus on toxicities of cancer therapies and cancer treatment options in the setting of chronic kidney disease. He has an interest and expertise in the use of population-level healthcare administrative data for clinical research. Dr. Kitchlu has published numerous scholarly articles, many focusing on the impact of multiple myeloma and its various treatments on kidney function. Welcome, Dr. Kitchlu.
So thank you so much for that very, very kind introduction, Patrick. And I really do want to take a time to thank Patrick, Renat, and the steering committee for this opportunity to speak to you at this type of venue. I'm fortunate that I get to give quite a number of talks, but this is the first time I've had the opportunity to give a talk predominantly focused towards a patient audience. And I realize in the nephrology or kidney medicine world, we likely don't do as good a job as those in the myeloma and cancer world of having physicians and those working in the area of kidney medicine communicate to patients. So this opportunity is so valued, and I'm really humbled and honored to be here. I also realize I am competing against a very beautiful Saturday afternoon that has no business being this warm in October. So I appreciate everyone's time and interest in attending this. I'll try not to ramble on too long, and I'll be mindful of the 3 o'clock time to give everyone an opportunity for break. If possible, I'll even try and sort of wrap up some of the main content and maybe leave just some questions for afterwards. Disclosures, so I do receive some funding from Amgen and Janssen in the pharmaceutical industry space to support a clinical fellowship training program to train kidney physicians who are interested in dealing specifically with patients with cancer. Another disclosure, I'm also returning from some travel last night, so if I'm a little brain foggy, it's because of jet lag. So an outline for what we'll discuss today. I'd like to give you a brief overview of what our kidneys do. And this is outside the setting of myeloma itself, but I think a helpful way for us to remind ourselves of the various roles of our kidneys in our body's health overall. Then we'll specifically move on to multiple myeloma in the kidney. We'll talk about how frequent kidney disease is in patients with myeloma and how it might influence myeloma outcomes. We'll speak specifically about the effects of some of the abnormal proteins that occur in the blood in myeloma and how these can be harmful to the kidneys. We'll talk just a little bit about myeloma treatment. That's not really an area that I want to step too much on the toes of my myeloma physician colleagues, but I wanted to give you some of my perspective as a kidney specialist of some of the effects of myeloma drugs on the kidneys and some of the nephrology techniques that have been used to try and help recovery of the kidneys in this setting. We'll talk a little bit about stem cell transplant and its safety in patients with kidney disease. And then lastly, just touch on a few newer drugs in the kidney disease space that we very much use in patients with myeloma as well, and hopefully have some time for summary at the end. So let's begin off the bat with the basics of what our kidneys do. Just as a reminder, our kidneys are two organs that sit towards the back of our bodies, about fist size, and they sit just below the rib cage. Many people recognize the job of the kidneys is to produce urine, but I think actually the main product of the kidneys is balance in the body. What our kidneys do is help us remove waste and toxins from the blood and help us get rid of excess fluid that we drink. Believe it or not, our kidneys actually filter almost 200 liters per day of fluid. Thank goodness we are not peeing 200 liters out every day. We'd spend all of our time in the bathroom, but our kidneys help us reclaim some of that water, helps us keep good things, and helps us get rid of excess fluid. It helps us balance acid and base, and help keep important electrolytes like sodium, potassium, and phosphate in balance in the body. It also helps us control our blood pressure, and it helps us send signals to the rest of the body on how tight to keep our blood vessels in order to keep blood pressure up. It also sends signals to the bone marrow to produce more red blood cells. And then lastly, the kidneys are involved in maintaining balance in things like calcium and has an important role in activating vitamin D in the body, which helps us maintain our bone health. So lots of jobs for the kidneys, not just making urine, in fact, maintaining balance in the body. So how does this actually work? So our kidneys receive blood through a large blood vessel here called the renal artery. My pointer may not show up, but the red blood vessel here is blood flow into the kidney, and the kidneys receive unfiltered or unclean, if you will, blood. This large blood vessel then branches into many smaller blood vessels until it reaches very tiny, small capillaries, very small blood vessels that act as the filtering portions of the kidney. And I'll show you in a second just what these look like. The clean blood contains lots of substances our body needs, including amino acids, vitamins, hormones, and electrolytes. And the veins can collect this and return it to our bloodstream. Meanwhile, all of the waste products that have been filtered in the tiny filtering portion of the kidney are collected into a tube called the ureter, and that makes its way to our bladders and then is passed out of the body. Thankfully, as I mentioned, we filter much more blood than we actually excrete in terms of urine, and this is because of successful kidney function hanging on to things that we want while getting rid of excess waste and excess fluid and electrolytes. So just a little diagram of the functional part of the kidney. I showed you the renal artery, the vein, and the ureter, which allows us to excrete urine. But within the working part of the kidney, or the kidney parenchyma as it's called, we have millions of tiny functional units called nephrons. And here on the right side of the screen is the image of the nephron. And essentially, the large sort of reddish ball that you see at the top here, I'm not sure how well it projects, but this is a clump of very tiny blood vessels that act as a filter. And those blood vessels are under pressure, and they're permeable, or they allow filtration of things like salt and water into a large collecting system called the tubules. And the tubules give an opportunity after that filter to reclaim some of the good products from the bloodstream that we want to retain in the body. So again, the glomerulus is this tiny filter that allows us to excrete waste and keep good things like blood cells and protein. When there is damage to this filter, we start seeing the kidney being leaky to things like blood and protein, and we can actually detect this in the urine with tests on the urinary system. So let's get into a little bit of how we can assess kidney health. Because of the fact that myeloma can affect the kidneys, we're going to come back to this concept of this glomerulus and filter and the tubules that help us reclaim some of the good products from the body. So we can estimate how well the kidneys are doing using blood tests. And the main blood test you might see on laboratory results is something called eGFR, or estimated glomerular filtration rate. That's a test which lets us know how good a job our kidneys are doing in excreting waste products from the body. And this result comes from another laboratory test called creatinine. And this might be something you might have seen particularly on your blood work results. Creatinine is a waste product of muscle and protein metabolism. And normally our kidneys help us excrete excess creatinine into the urine. When the creatinine level rises in the blood, it's an indicator that the kidneys are not doing a good job in getting rid of creatinine. But because I mentioned that creatinine is also a byproduct of muscle metabolism and protein intake, that creatinine level doesn't just reflect kidney function. Folks who have a higher level of muscle mass and may have higher protein intake will tend to have a higher creatinine result as well. And to get around this, we try and correct that creatinine number for things like age and sex, because there are differences at various levels of age and in males versus females in terms of what's expected for the creatinine level. And that eGFR result is essentially correcting the creatinine test for what we expect for people of similar age and sex. So when you're looking at your lab results, this is what that eGFR number means. As a reminder, a higher creatinine level lets us know the kidneys are not getting rid of excess fluid, but that translates into a lower eGFR. And some people even view that eGFR level as something like a percentage of the level of kidney function. I'll also mention we look at urine tests, and I highlighted earlier when the filtering portion of the kidney is damaged, the urine can develop blood or protein in the urine. In other words, the filter is leaky to blood and protein. And this shows up in our urine tests. We can do what's called a dipstick urine test that identifies the presence of blood in the urine and can give us a rough quantitation of protein in the urine. These days we have even more accurate measurement to determine the actual amount in milligrams of protein that's leaking into the urine test. And we can even detect myeloma-related proteins in the urine as well. And so I know many of you are familiar with doing 24-hour urine collections, which we recognize is no picnic to do, but your nephrologists and your myeloma doctors really appreciate you completing this because it lets us know how much myeloma protein's in the urine and whether the kidney is leaky to urine protein overall. So as I mentioned, we use these two tests primarily to identify the level of kidney function. And we try and use this eGFR number to give us a scale of how good overall the kidneys are doing in terms of excreting waste from the blood. eGFR numbers in the 60 to 120 range are reflective of normal kidney function. When we get below 60, we start to consider this as a presence of kidney disease. And numbers below 15 let us know the kidneys are usually not doing a good enough job to excrete waste from the body, and that's in the setting where we think about the possibility of kidney failure and needing to use treatments to do the work of the kidneys when they are not doing their job. So to highlight this concept again, we can actually use the level of the eGFR tests and the urine protein to give a prediction of what the risk of worsening kidney function might be. So on this side, the left side of the screen, you can see lowering levels of GFR. In other words, a lowering ability of the kidney to get rid of waste. And on the right side, you can see higher levels of leakiness to protein. And the worse a job the kidney does in getting rid of excess waste and the more leaky it is to protein, the higher the likelihood of kidney function getting worse over time. And so the areas in red reflect high risk to the kidneys based on these two tests, whereas green and yellow represent lower risk. And this is how we can use both blood tests and urine tests to predict where things will go in terms of kidney function for patients. It's important to recognize that a few things can cause acute changes or short-term changes in kidney function. We generally classify these in three big categories. The first is pre-renal, and what that means is the kidneys are not getting adequate blood flow. Usually this can be caused by things like dehydration. This can happen with illnesses, particularly things from the gastrointestinal system, like nausea, vomiting, or even just poor oral intake. These can lead to a degree of dehydration and therefore reduce blood flow to the kidneys. The second category is true or direct damage to the kidneys. This can happen from things like medications or drugs. It can also happen from things like abnormal proteins in the blood related to myeloma, and we'll describe how that happens in just a little bit. And then the last category we call post-renal. In other words, it's reflecting blockages in the urinary tract after the kidneys. So blockages that can occur in the ureters or the bladder that prevent us from getting rid of urine, and this too leads to decreased kidney function. Another quick point to raise is that there is this concept of acute kidney injury, meaning a short-term hit to kidney function. If this occurs in a more severe setting or there is poor recovery or healing from the kidney, over time, this can lead to the development of chronic kidney disease, and we generally think of a low level of kidney function that's been present for more than 90 days as reflective of chronic kidney disease as opposed to something that's acute and reversible. People often ask, what are the potential symptoms of low kidney function? Unfortunately, symptoms of kidney disease can often be nonspecific. They can be driven by multiple different factors, but things like itchiness in the skin, tiredness, swelling or the retention of fluid in the body. That can lead to swelling in the hands or feet or puffiness in the eyes. Presence of very foamy urine sometimes points towards leakiness to protein. And other signs of toxin buildup like loss of appetite, muscle cramping, or difficulty sleeping can all reflect lower levels of kidney function. But you can imagine many conditions can lead to these types of symptoms. Even myeloma itself can lead to symptoms like fatigue. Sometimes the medications we use to treat myeloma can result in these types of symptoms. So it's important to make sure that we are confident symptoms are due to low kidney function. And earlier I showed you that eGFR scale of where kidney function is estimated to be. Usually we don't see symptoms of low kidney function until that eGFR number is less than 30, so moving from that orange towards the red range as opposed to the yellow and green ranges, which reflect some reduced kidney function but shouldn't cause symptoms of kidney disease. So what do we do when the kidneys are not doing their jobs? And I just wanted to briefly bring up two forms of treatment that we use when the kidneys are not doing their work. Of course, we could spend quite a lot of time getting into the details of this, but I just wanted to give a very brief overview of the first treatment, which is called hemodialysis. This is where we use a machine with a filter attached to it to do the work of the kidneys when the kidneys are not doing their job. In this diagram here, you see a patient who is having a connection of a special type of intravenous that takes blood from the body, passes it through a series of pumps within this machine, and then passes it through this filter, which is shown on the schematic here on the right. So the red blood, shown sort of at the top here, enters the filter, and in the opposite direction, we use a special type of fluid called dialysate. Toxins from the blood can pass through the filter and move into the dialysate, and then the dialysate can be discarded. Also, things that we want to replace in the blood, including things like electrolytes or even medications that we'd like to give, can be placed in the dialysate treatment and can enter the bloodstream that way. With the dialysis machine, we can get rid of excess fluid, and we can even set the amount of fluid we want to remove. So for example, if the kidneys are not making the urine they should in a day, for example, 1 or 2 liters of urine production in the day, the dialysis machine can get rid of that excess fluid for us. The way that we usually provide dialysis in the hospital is usually 3 to 4 times a week for 3 to 4 hours at a time. And in doing this, we try and mimic the amount of cleaning of the blood that would happen with our own kidneys and the amount of fluid removal that would happen from making our own urine. But you can imagine that 3 or 4 hours a day, 3 times a week, is not as good as the 24-hour function of our kidneys. And so this is a bit of a substitute for a more perfect system designed by nature. And I'll mention also, people often wonder, does the dialysis treatment help the kidneys heal or recover? The dialysis treatment is more akin to a spare tire. So when your own kidneys are not doing the job, the dialysis helps keep things moving along until your own kidneys can recover, or for example, for myeloma treatment to do its job. It doesn't do work directly to heal the kidneys per se. So hemodialysis is one form of how we keep things moving along when the kidneys are not doing the job. As a last point, I'll mention for people who need longer-term dialysis treatment with hemodialysis, these days, particularly in Toronto, we do a lot of home hemodialysis where patients can set up the dialysis machine in their own home. They need a little bit of training to be able to use and set up the machine, and usually some support with family members or visiting nursing. But many people can do dialysis treatments at home, particularly with some of the expertise we have in Toronto these days. Apart from the hemodialysis option, there is a second common option for dialysis called peritoneal dialysis. And again, not sure how well it projects, but you can see here tubing that is connected to a patient's abdomen here. And here we have a special type of tube that's placed in the abdomen that allows us to enter fluid into the body. And this is what this hanging diagram on the pole is showing us here. Fluid can be entered into a space in the abdomen called the peritoneum, and there's a natural membrane that exists in that area of the abdomen. Fluid that sits in that area can allow toxins to leach into it, and so usually people carry this fluid in the belly for a period of 3 or 4 hours at a time. It absorbs toxins from the bloodstream, and then we drain that fluid out from the body using that same tubing. Usually people do this at home, and usually they'll do some of these exchanges of fluid during the day 3 or 4 times to allow this dialysis fluid to remove toxins from the body. It also can help us remove excess fluid. It may not do quite as good a job as the hemodialysis treatment in some regards, so people often need to have a little bit of leftover kidney function to do this form of dialysis, but the big plus is that it can be done from home. As I mentioned, all of these are spare tires, so to speak. They're not as good as our own normal kidney function, but many people can do dialysis at home and have a lot of freedom around their dialysis care. And I think we've come a long way from some of the older periods where dialysis was not accessible at home, and we did a much poorer job of cleaning toxins from the blood using our current dialysis machines. So I think there's been a lot of improvements in this space recently. So this is a little bit of overview of what the kidneys do and what we do for the kidneys when they are not doing their job. Let's move on to talk a little bit about how myeloma can affect the kidneys. So first, let's talk a little bit about the incidence of kidney issues in myeloma patients. Unfortunately, kidney injury is very common and can affect the kidneys in multiple different ways in folks with myeloma. About 20 to 50% of patients may have either acute, as in short-term kidney issues, or more chronic kidney problems. In folks who have a new diagnosis of myeloma, about 3 to 12% of them may require dialysis initially at the time of the start of myeloma treatment. Many of those folks, if myeloma treatment works well, can recover their kidney function. And Patrick mentioned earlier that a change in kidney function was what pointed to his myeloma diagnosis. I think we're fortunate these days with effective myeloma treatment. Many times kidney function can improve after correct myeloma therapy. So just a little bit about the way that we talk about myeloma and the kidney. The way most myeloma doctors would describe kidney disease related to myeloma would be using a term called renal impairment. And this historically has been described using a creatinine number of 2 in American units. This was kind of a nice round number for them to pick in the US units for creatinine levels in the blood. As it happens, we use different units here in Canada, and the equivalent of a creatinine level of 2 is 177 in our units. And so this is what's often considered low kidney function in myeloma patients if you're reading literature around myeloma-related kidney disease. As I mentioned, for kidney health otherwise, we use this grading system with the eGFR levels. And as we talked about earlier, numbers 60 or greater reflect mildly reduced or normal kidney function. And as we get into categories less than 60, that represents more significant kidney disease. We also talked about how we use protein levels in the protein levels in the urine to quantify the damage to the kidney in terms of leakiness to protein and help us predict where kidney health may go in the future. So just a little bit to show you how changes in kidney function may influence myeloma outcomes. This is a large study done in France between 2002 and 2015. They had over 1,000 patients with myeloma and about 250 with renal impairment, meaning this creatinine level greater than 2. You can see that survival was much better in patients who had preserved normal kidney function. And so it's very apparent that reduced kidney function has a big impact on overall myeloma survival. And this can be a reflection of the severity of myeloma in terms of its effect on the kidneys, but also reduced kidney function leading to things like the need for dialysis, the susceptibility to other problems like infections, and the ability to use certain myeloma-related medications. Here's just a similar study in US patients. These were patients enrolled in the US Medicare system. This is 22,000 individuals, of whom about 40% had what we'd consider chronic kidney disease. And these varying colored lines represents the severity in terms of stages of chronic kidney disease. And again, showing here that the more severe your kidney disease, the worse things are in terms of overall myeloma survival. So it's very important that we try and preserve kidney function to allow for better outcomes in terms of myeloma survival. An important thing to recognize is that even for patients who have some initial injury to the kidneys, so here we're showing patients who are requiring hemodialysis or HD at the beginning of myeloma diagnosis. Those who were able to come off dialysis and had recovery of kidney function had a very similar overall survival to patients who never had kidney disease in the first place. And so it shows us that reversal of kidney damage with correct myeloma treatment can lead to similar outcomes with respect to survival. So this is a really positive and hopeful indicator for us. Compared to other cancers, myeloma has the highest rates of both acute kidney injury and need for dialysis. About 10% of patients may have blood work changes in keeping with acute kidney injury, and over 5 years, up to 26% may have hospitalization or need for dialysis over time. So let's just discuss a little bit about how myeloma proteins can affect the kidneys. As you know, with myeloma, there is production of abnormal proteins and what are called light chains in the blood. Normally, our kidneys have the ability to filter out those abnormal light chains. So we showed earlier this diagram of this filtering unit in the kidneys called the glomerulus. And these little yellow bits here, which I apologize, don't project particularly well, but these yellow bits that are floating down this tubule represent abnormal light chains. And normally in this tubule, we have the ability to resorb and digest or break down, if you will, abnormal light chains. Normally there's a very minimal amount of light chain present in the blood, and so our kidneys can handle this well. But in the case of myeloma that's active, there can be overproduction of light chains, and this can exceed the ability of the kidneys, in particular this tubule section of the kidneys, to absorb and digest these abnormal light chains. And over time, these yellow particles here can move their way down through the kidneys and connect to another type of protein that's normally found in the urine. And they can actually cause obstructions or blockages in the kidneys and within the tubules themselves. We call this CAS nephropathy. It used to have the term myeloma kidney because it would happen so often in patients with myeloma. Thankfully, these days we do a much better job of reducing light chain levels, but the possibility of this CAS nephropathy condition is still present. So just to mention, when there is damage to the tubule section of the kidneys with these abnormal light chains, we can see problems in the urine tests. We see more issues with acidification of the blood. We see leakiness in the urine to things like sugar. So sugar can become present in the kidneys. And there's also loss of normal amino acids that our blood holds onto into the urine. This is what I was mentioning earlier in terms of these green little particles here representing myeloma proteins binding to normal protein in the urine and causing these little micro blockages that lead to damage or inflammation in the kidneys. These can cause permanent scarring or damage to these filtering or working parts of the kidneys and lead to long-term changes in kidney health that sometimes are irreversible. There are a few risk factors for myeloma proteins to affect the kidneys. Some of it relates to what we call volume depletion. This is sort of a fancy way of saying dehydration. So folks who have illness for other reasons, things like viruses or infections that lead to dehydration, or people who are on diuretic treatments or water pills. Also, problems with acid-base balance in the body can lead to a higher chance of forming these abnormal proteins in the urine. And so for people who need correction of that acid-base balance, we can actually prevent some of the formation of these abnormal proteins. High levels of urine calcium, which can happen in certain conditions related to the metabolic or endocrine system, and recent exposure to contrast, which is a type of dye we use in CT scans, can also increase the chance of kidney injury from these mechanisms. Lastly, some anti-inflammatory medicines like Advil or Aleve can be hard on the kidneys, and they can increase the chance of myeloma protein damaging kidney function. So this is another potential risk factor for this CAS nephropathy condition. I'll mention sometimes apart from the tubules being harmed by the kidneys, myeloma proteins can sometimes deposit in the filtering part of the kidneys as well. And there are many different descriptions we have for this based on what we see at the microscopic level within the kidneys. I won't get into detail with any of these sort of more jargony descriptions, but with these types of conditions, in addition to seeing myeloma protein in the urine, we also see loss of urine protein overall. And when this happens, swelling and the retention of fluid is much worse in the body. And so this is the type of change we see when there is damage within the filter itself. I'll mention that apart from the proteins from multiple myeloma harming the kidneys, there are a few other potential reasons for kidney damage that can happen. One is high calcium levels in the blood. When calcium is very high in the blood, it can actually cause decreased blood flow from the kidney to the kidneys. Many patients receive treatments like bisphosphonates, Zometa or zoledronic acid to keep calcium levels under control. And in doing so, we prevent some of the chance of calcium-related damage to the kidneys. Things like infections or sepsis are unfortunately common, and so these can also result in decreased blood flow or dehydration to the kidneys. Sometimes we actually see myeloma cells entering the kidney itself. This is quite rare. We see this in less than 2% of patients, but we call this plasma cell invasion. And then lastly, some of those bisphosphonate drugs I mentioned, which help control calcium in the blood, they can also lead to some direct toxicity to the kidneys. And so that leads to specific conditions that are as a result of drug-related harm to the kidneys. And so we're quite cautious with this. And lastly, certain myeloma therapies have also been associated with toxic effects on the kidneys, and we'll describe these in just a moment. In terms of diagnosis of which form of kidney injury is influencing the kidneys, there are certain rules we use based on the levels of light chains and the levels of protein in the urine. I won't get into great detail with all of these, but I'll say that when light chain levels are very, very high, we can make a presumptive diagnosis of this CAS nephropathy condition. Sometimes if myeloma levels are not that high, but we're still seeing worsening kidney function, the way that we can determine what's going on within the kidney itself. So I'll just conclude by saying in some situations to diagnose what's happening in the kidney related to myeloma versus other conditions, we do need to consider getting a kidney biopsy test, and that's where we use a very small needle to get a tiny sample, much less than 1% of the kidney, but it's enough for us to look under the microscope as to what's happening with the kidneys, and it can show us conditions like this CAS nephropathy condition I mentioned earlier. Also, some of the conditions that are related to myeloma, like amyloidosis, can be found on kidney biopsy as well. So there are certain situations to guide us based on the levels of free light chains and the amount of protein we're seeing on the urine tests. So this is part of the reason we hassle people for these 24-hour urine collections. I'll just mention that the findings on kidney biopsy can also help us predict where kidney health may go. So the degree of what we call fibrosis or scarring present on the kidney biopsy can give us clues as to whether kidney health will recover or whether things like the creatinine levels or eGFR levels remain stable or the same. I'll just mention there's a few things that we can do generally to try and prevent kidney damage related to myeloma. Generally, we try and increase fluid intake. We had a question earlier of what that amount should be. Somewhere in the vicinity of 2 to 3 liters per day is usually enough to avoid dehydration. But we try and tailor this to patients' individual body size and other conditions that can influence their kidney health, like the presence of high calcium levels in the blood. For higher calcium levels, for higher body size, we increase that fluid intake amount. We consider holding some medications like diuretic or water pill medicines and certain blood pressure medicines. And then for situations of high calcium, we think about certain drugs which can lower calcium levels by taking calcium from the blood and putting it into the bones. And we generally just watch out for some of the potential harmful effects of these medications on the kidneys, so we often repeat kidney blood work and urine testing after some of those medications. I won't get into too much of anti-myeloma drugs themselves. As you guys are well aware, there's lots of updates in the space of myeloma drugs, but in general, for CAS nephropathy, treatments that are based on bortezomib and some of the newer proteasome inhibitor drugs have been the mainstay of therapy, and these have allowed for recovery of kidney function in patients who have CAS nephropathy. Just a little bit of discussion on some of the drugs that are used these days and their potential kidney effects and some of the dose adjustments. I won't belabor this because I know that the information pertaining to this should be looked at by the myeloma physicians and the pharmacists, but just as a heads up for some of the drugs that could have kidney effects, I think it's nice to have a little bit of an overview. So bortezomib, as I mentioned, is one of the most commonly used drugs. Velcade is its brand name. Fortunately, kidney problems caused by bortezomib are very rare. There's been very scattered cases of a condition of inflammation in the kidneys called thrombotic microangiopathy, but these are limited to the number of case reports and not very common overall. There are no renal dose adjustments for bortezomib, so even at very low levels of kidney function or the need for dialysis, patients can continue on this treatment. There is a recommendation that kidney function should be monitored closely when that eGFR number or creatinine clearance is less than 30, but we tend to do this anyway for patients who have those levels of kidney function. Another drug is carfilzomib. It also goes by the brand name Kyprolis. This has some more potential for this thrombotic microangiopathy condition, which is a type of inflammation of the blood vessels of the kidneys. And in some of the larger studies of this drug, up to 20% of patients had an episode of acute kidney injury, but it's sometimes difficult to distinguish this from harm to the kidney caused by the drug versus changes in myeloma itself. There is a recommendation for holding the drug if there is a short-term change in creatinine level and to resume the drug at a lower dose if kidney function recovers to within 25% of the pretreatment baseline. Ixazomib or Ninlero is another commonly used proteasome inhibitor drug. It is not very frequently associated with this type of inflammation in the kidney. There is mostly metabolism through the kidneys of this medication, but no major dose changes around lower kidney function or dialysis. Some of the immunomodulator or IMiD drugs like thalidomide, lenalidomide, Revlimid, these have some kidney dose adjustments, not so much on thalidomide, although this is less commonly used these days. Revlimid does have some adjustments based on what the level of EGFR is. So for levels 30 to 60, we suggest 10 milligrams daily. For less than 30, 15 milligrams every other day. And for less than 30 or dialysis requirement, there's a little less certainty around the optimal dosing, but one suggestion has been a 5 milligram daily dose. Pomalidomide is a newer immunomodulatory drug. It is also excreted primarily in the kidneys, limited data in the setting of more reduced kidney function. One of our recent graduate students did some research using Ontario data on this medication. I won't belabor this too much, but what this great student did was they looked at various levels of kidney function in patients receiving pomalidomide and looked at myeloma outcomes, kidney changes, and some of the safety outcomes related to the side effects of pomalidomide. And what they were able to find was that there was no difference in overall survival in terms of patients with even more severe kidney disease, suggesting that maybe pomalidomide had some benefit even for patients who had more significant kidney issues. There was no difference in kidney damage or kidney harm, which was a very positive indicator as well. And although there was a little bit of an increased signal towards more frequent anemia related to the drug, there was no difference in other safety or side effect outcomes, including things like emergency department visits or hospital stays. So this was just one example of research led by some of our local colleagues that can examine the use of myeloma drugs even at lower levels of kidney function. I won't get into too much of details about some of the treatments related to dialysis and stem cell transplant. I think we can save these if there are specific comments for this. And then I'll just touch on some of the drugs we use for treating chronic kidney disease apart from multiple myeloma. In other words, medications that can be protective for the kidneys overall, regardless of the cause of chronic kidney dysfunction. So for many years, our main way of treating kidney disease were a group of drugs called RAS inhibitors. That's the blue pillar on the left of the screen. These are a group of blood pressure medications that have kidney protective effects. And basically from 2001 to 2018, those were the only proven medications to help prevent the progression of chronic kidney disease. From 2018 to now, we've had 3 new classes of medications that can slow down the progression of chronic kidney disease. The first is a group of drugs called SGLT2 inhibitors. This stands for sodium glucose cotransporter 2 inhibitors. And these have emerged as a very important tool in being able to prevent the progression of kidney disease. So we'll talk about those in a little bit. And then lastly, in 2020 and 2024, there have been 2 classes of medications that have been helpful specifically for folks who have diabetes and kidney disease. We'll just touch on these briefly. So I won't get into the effects or the mechanisms specifically for these SGLT2 inhibitor drugs, but in short, what these drugs help us do is get rid of some excess salt and excess sugar into the urine. And in doing so, these seem to reduce some of the pressure on the filtering part of the kidney, that glomerulus group of blood vessels I showed you earlier. They seem to have less pressure in this area as a result of use of SGLT2 inhibitors. And apart from slowing down kidney disease, These also have multiple other beneficial effects shown in clinical studies, including the prevention of cardiovascular problems such as heart attack and stroke. So these have become a very important tool in our toolkit for patients who have kidney disease. I'll just highlight, this is a set of data from multiple different causes of kidney disease. So everything from diabetic kidney disease to high blood pressure related to kidney disease, and even inflammation causes of kidney dysfunction. All of these seem to benefit in terms of reduced risk of progression when we use these SGLT2 inhibitor drugs. So these days, if you're seeing a kidney specialist and myeloma is under good control and we want to prevent the progression of kidney disease, most often our main two tools are blood pressure medicines and these SGLT2 inhibitor drugs. To give you a little bit of diagram of how these can change kidney outcomes for a patient, the graph here shows us estimated glomerular filtration rate, or eGFR, and it shows changes in time when using these SGLT2 inhibitor drugs. And believe it or not, when you first start the treatment, you actually have a drop or decrease in eGFR, but what these drugs allow for is stabilization of the slope of eGFR over time. In other words, if we look at the rate of change of kidney function over many years, people who are on this group of drugs have a much more stable level of eGFR versus people who are not on medications. And so the time to reach more advanced kidney disease, or God forbid, kidney failure, is much better for patients who are using the SGLT2 inhibitor medications. I'll just mention, as we talked about earlier, the chance of cardiovascular disease, including death from cardiovascular causes, is also very significantly improved with this group of medications. So these are a very beneficial drug to consider, and one that many nephrologists would suggest to patients who have some kidney disease. I'll mention more recently there's been a group of medicines called non-steroidal mineralocorticoid receptor agonists. These are drugs that also work on reducing blood pressure, and they're also a form of water pill type medication. Most of the benefits of this group of medications has been shown only in patients who have kidney disease and diabetes. But for people who do have certain levels of kidney function based on their eGFR test, and who have changes in terms of protein in the urine, use of this group of medicines is another beneficial add-on to classic blood pressure drugs and the SGLT2 inhibitor family of medications. So this is a third option for folks with diabetes. And then the last new big drug update is use of glucagon-like peptide-1 receptor agonists. These are the so-called GLP drugs that go by the brand names Ozempic, Wegovy. Their generic name is semaglutide. And so you may have seen quite a lot of furor in the news about these types of medications in terms of treating obesity and allowing for weight loss. People have looked at these for preventing chronic kidney disease progression, and for both patients with diabetes and those without diabetes, there is some emerging data to show us that drugs like semaglutide or Ozempic may have some protective benefit. I think there's more data to come in this area, but Ozempic and its cousins are another tool potentially in the toolkit to prevent the changes in kidney disease in the long term. So based on some of these new medications in the last few years, we've updated the overall guidelines for prevention of chronic kidney disease. And what I'd like to draw your attention to first, and maybe most importantly, is the green box along the top, which highlights that diet and lifestyle are the foundation apart from any other medications. So maintaining healthy diet, physical activity in the range of 30 minutes daily, at least 5 times a week, is a recommendation to help prevent chronic kidney disease progression, and particularly to help with blood pressure control. Avoidance of tobacco products and smoking, and maintaining a healthy weight is also key aspects in terms of maintaining kidney health. And then for most folks, use of blood pressure medications, ideally to target a blood pressure of less than 120 for the systolic or top number blood pressure, and the use of these SGLT2 inhibitor drugs are the first choices for most patients. We also consider cholesterol-lowering medicines like statins to reduce the chance of cardiovascular disease. And then for folks who do have diabetes, these most recent two medicines, the non-steroidal MRA drugs and the GLP-1 drugs like Ozempic, are considerations for people who have diabetes as well as kidney disease. Just a quick point that on days in which there is acute illness, God forbid, a virus, stomach bug, bad cold or flu, it's a good idea to hold off on medicines like blood pressure drugs and water pills. And the intention here is to avoid dehydration that can happen when people are not eating and drinking well, but are taking water pill medications. Similarly, we don't want blood pressure to drop too low when people are dealing with a bad illness related to virus infection, something like this. So if you have doubts about which medicines to continue at the time of an acute episode of illness, please talk with your physicians about which medicines you are safe to continue and which to hold. This stop pills column here, which includes diuretics or water pills, the ACE inhibitor or ARB blood pressure drugs, the SGLT2 inhibitor medications, anti-inflammatory drugs like Advil or Aleve, and metformin are generally medicines that we should put on hold when there is acute illness. So I realize I've kept you guys too long. I just want to summarize with some final points. I think overall, kidney disease is unfortunately frequent in the setting of multiple myeloma and does have some important implications for myeloma outcomes. Fortunately, though, kidney injury from myeloma is treatable, especially with newer myeloma therapies, and most myeloma drugs are safe for the kidneys. Some do have some potential harms and need some dose adjustments based on the level of kidney function. There are newer treatments for chronic kidney disease, including some of the newer drugs we touched on towards the end, and these may have beneficial effects for multiple causes of kidney disease, but for myeloma as well. So with that, I'll wrap up the slides and would be very pleased to take your questions. Thanks very much.
I have a lot of questions, but I'll start. Thanks, Dr. Kitchlu. Two questions. One is, with high blood pressure medication, cholesterol medications, and so forth, how exactly does cholesterol or blood pressure impact on the kidney? What damage does it do? That's the. Yeah. I'll hold the other question.
So thank you for that question, Patrick. We know that high blood pressure is both a cause and a consequence of worsening kidney function. And maybe one thing I did not stress enough is the glomerulus, or that filtering section of very tiny blood vessels in the kidneys, that is quite sensitive to blood pressure changes. And we know that over time, exposure to high blood pressure can lead to damage, what we call sclerosis of that filtering portion of the kidney. And so for this reason, for people who do have some reduced kidney function, we're really aggressive, I'd say, in trying to keep blood pressure under good control. And so there's been a specific group of blood pressure medicines. That was this blue pillar, the RAS inhibitor family of medicines, which includes a subgroup of medicines called ACE inhibitors and another called ARB, or angiotensin receptor blocker drugs. These two families of blood pressure medicines are those who have been shown not only to reduce blood pressure, but to have a long-term kidney protective effect. And in studies, they've been shown to reduce the change in EGFR levels over time, but also for people who do have kidney disease, to reduce the chance of heart attack and stroke. And so for these reasons, protecting blood vessels, not only in the kidneys, but also in the heart, in the brain, are very critical for folks who do have some reduced kidney function. You also asked about cholesterol medications as well. And so cholesterol medications reduce primarily the chance of cardiovascular problems like heart attack and stroke, including in patients with kidney disease. They have not been shown to have a clear change on kidney function over time, but the reason we still suggest them in patients with kidney disease is we know that people who have some reduced kidney function have a higher chance of things like heart attack and stroke. And so we are more aggressive in trying to reduce the chance of those cardiovascular events in patients by keeping cholesterol levels under good control. Generally, we look at levels of kidney function and a type of cholesterol test called LDL, or low density lipoprotein, which is the type of cholesterol that's bulky in the blood and has a chance of forming things like plaques or narrowings in the blood vessels. And the cholesterol medications, particularly the statin drugs, help lower that LDL level and thereby reduce the chance of cardiovascular events for patients who have kidney disease. So we're a little bit more stringent about cholesterol levels, and if you're seeing a kidney doctor, in addition to doing your blood and urine tests for kidney function, they'll also often look at your cholesterol profile and also often look at your blood sugar to make sure those risk factors for cardiovascular disease are being looked after as well.
Are there any non-pharmaceutical therapies or interventions that you would recommend to maintain optimal kidney health? Because I heard you mention, for example, vitamin D, and I'm sort of thinking about these sort of holistic options that might be available.
Yeah, so that's a great point. I think the two sort of overarching aspects of non-pharmacologic management of kidney disease, and that's, I think, actually a key reason why we put this sort of at the top level of the guideline recommendations, because without the foundation of diet and lifestyle, any medication or pharmacologic add-ons are reduced in terms of their benefit. But key things that we recommend in terms of diet and lifestyle are making sure that you have a diet that's lower in salt and fat content overall. And I realize we didn't get sort of an opportunity to get into a lot of the details around this, but we opt for a lower salt and fat content precisely for those cardiovascular reasons that we touched on in Patrick's question. Generally, a lower salt content in the diet allows for more normalization of blood pressure. And so if you're reading package information about nutrition, they will often, actually they are required now to report how much sodium they contain. And if you're counting up your sodium over the course of the day, aiming for less than 2,000 milligrams of sodium content is shown to help better control blood pressure, and in some studies seems to lead to better long-term kidney function. I say some studies because long-term nutritional data is very hard to accurately assess, but I do think keeping an eye on sodium in the diet, especially in our Western diet that is so heavily laden with salt, is a really important thing. Actually, regardless, our international diet, let's say, is very salt heavy, and so being cautious with sodium intake is an important thing. In terms of other lifestyle things, cardiovascular exercise is important to helping control blood pressure, but also reduce the risk of cardiovascular events like heart attack and stroke. So there is not sort of a specific regimen that we suggest people do. I think it's more important to pick something that is sustainable for you in terms of regular exercise. So, if you like walking, jogging, swimming, whatever floats your boat that you're able to continue with, I think is the best strategy for long-term sustaining of exercise. People have asked about supplements that may lead to kidney benefit, and there have been a lot of studies looking at things like omega-3, fish oils, various vitamin supplements. Unfortunately, none of these, including sort of vitamin D that you mentioned, have been shown to have a benefit in terms of either change in progression of chronic kidney disease or reduced cardiovascular outcomes. And so one that we used to suggest in the past, omega-3, we've kind of had this fall out of favor a little bit more recently. But my hope is other supplements may emerge that have benefit in this space. I think if you were to invest your time and effort, it should be on those first two aspects in terms of maintaining a healthy diet and maintaining physical exercise. Other supplements have less data to guide their benefit.
Is there some question that we should ask a doctor when they suggest that CT scan that we might have to get, they're going to use contrast, or possibly if you're getting some kind of heart stress test where you're not on a treadmill but they're giving you contrast, should we inquire about what the dye is, or how do we get rid of it afterwards in the event that they say you should do this?
So that's a really great question, and something that has had a lot of controversy in recent years. So for many years we thought the risk associated with contrast dye was particularly high, and I think in some cases we actually avoided important information for patients because of the potential risk of things like CT scans and heart angiograms in particular. The newest data that suggests that the risk associated with CT contrast dye is actually likely very low, and only for folks who have an EGFR less than 30 should we have more caution regarding contrast dye. And usually when you're going for a CT scan, particularly like at our hospital at University Health Network, we will check blood work in advance of a CT scan, and we'll ask patients about, do they have a recent kidney blood test? If they do, then we do try and reduce the risk of some of the contrast dye with use of IV fluids to try and flush out, if you will, or increase the clearance of contrast dye. There used to be other medications that we would consider in this setting, but to be honest, none of them showed benefit in protecting the kidneys from the effects of contrast. But this is probably because the additional risk of contrast with CT scans is pretty low. This is a little bit separate from the contrast that's used for heart tests like angiograms, where there is a larger amount of contrast used. For this, if kidney function is low, as in if there is a EGFR level less than 30, usually the cardiologist will reach out to the kidney doctor to see if there are things to change in terms of medications. So we often put medicines like diuretics or water pills on hold. Some of those sick day medicines that I mentioned earlier, like the blood pressure drugs, are often kept on hold. And even medicines for blood sugar like metformin are temporarily stopped. Still, I think if there's an important question to be answered for the heart, if there is a concern of narrowing the blood vessels of the heart, most often it's very important to get that information available, because if there is the possibility of opening blood vessels of the heart or using stents to prevent further narrowing, I would say most folks would accept some risk to kidney function while providing the information or even an intervention that's beneficial for the heart. As a last point, for contrast-related kidney injury, most of the change in kidney function has been shown to be short-term, so people usually have recovery of their kidney function within 7 to 14 days after an exposure to contrast. So most of this is recoverable, even in the probably small number of patients who have a true contrast-related injury. And that's part of the reason we try and ensure that even patients who do have lower levels of kidney function can get appropriate heart testing, because that has a big impact on their future risk of cardiovascular disease and maybe future risk of kidney health as well. Thanks.
Thanks for your talk. Are there any specific populations in myeloma that are at higher risk for kidney disease? And if yes, do they require different monitoring?
So, if I heard correctly, are there specific subgroups of myeloma patients? So it's a good question. So folks who have Amyloidosis, as well as multiple myeloma conditions, are probably at increased risk of changes in kidney function over time. And this is as a result of the amyloid protein affecting the filtering or this glomerulus part of the kidney as well. Folks who have persistent high light chain levels and those who have high calcium levels are those who are probably at greatest risk otherwise. There is probably additional subtyping of myeloma that is related to the light chains themselves, because we know that certain light chains tend to be more likely to be sort of sticky to the proteins that are in the kidney and more likely to deposit. Unfortunately, we don't have a great ability to subtype those particular light chain levels. There is hope in the future that we may have drugs that target those specific light chains and their ability to bind to areas in the kidney, including the proteins that make this CAS nephropathy condition, but we are not there yet.
Are there any warning signs, early warning signs that might alert us to possible problem with our kidneys?
Yeah. So it's a great question, and one that we get asked frequently, because many people come to hear they have kidney problems and then wonder sort of backwards, like, was there some indication I could have known before? One of the sort of pluses and minuses of the kidney is that it's able to sort of keep going even when kidney function is very significantly reduced. And so I mentioned earlier that EGFR number of 30 is probably around the area where people start to develop some of these symptoms of things like fluid retention, so swelling in the legs or ankles, or even puffiness around the eyes, things like itchiness of the skin or decreased appetite that comes from the buildup of toxins. Usually happen when that level of kidney function is already low. What I would say as early indicators that we should all routinely have done as part of our regular health screening, number one, blood pressure should be checked for everyone, because high blood pressure is an indication that kidney disease may be present. Almost everyone who has some level of reduced kidney function can develop high blood pressure over time, so blood pressure is important to be screened and also be treated to prevent future changes in kidney function. Also, the urine tests, which are very sensitive now to be able to detect any leakiness of protein in the kidneys. So the presence of any protein on the urine test is an early warning sign that the kidneys may be affected. So these things require a bit of contact with the healthcare system to be able to identify, but I would say it's worthwhile to avoid later symptoms that indicate more significant kidney damage is already present.
And, some of these signs are evident. Should we be seeking a consultation with a nephrologist such as yourself or our family doctor?
So the good news is that, I'm just going to bring up the slide that has sort of the list of symptoms of kidney disease. The good news is that testing related to whether one needs to see a nephrologist is quite available and quite quick in our healthcare system, in the sense that if the EGFR level is abnormal, in most cases, if EGFR is less than 45, but even in the 45 to 60 range, there is very reasonable way to refer to nephrologists. Or if that urine protein level is increased, that's another reason to seek referral to nephrologists. And family doctors in Ontario have information through something called the KidneyWise Toolkit that gives them sort of guidance as to what levels of the EGFR test and what levels of the urine testing they should seek consultation with a nephrologist. So these things, fortunately, are kind of put through an algorithm for family physicians in Ontario.
I've heard so much about the benefits of coffee. Is it still safe to drink if your creatine is high? And also, if there are too much water or too many fluids to drink, if you drink over there.
Yeah. So two good questions. I would say one overall, coffee is generally safe in moderation, even in reduced kidney function. I know everyone can have a different definition of what moderation means, but somewhere in the ballpark of 0 to 3 coffees per day is probably in the realm of okay. The potential downsides of coffee is that it contains caffeine, which can have an impact on blood pressure. So we want to make sure that excess caffeine intake does not lead to a lack of control over blood pressure. There is probably also some diuretic effect from caffeine, but I think the impact of this is probably a bit overblown. And so as long as you're having enough fluid intake apart from your coffee, so you're eating and drinking other things over the course of the day, then that diuretic effect from coffee is probably minimal. You don't need to worry about excess effects of coffee on kidney health. And I do agree there are lots of studies these days showing the potential benefits of coffee intake. I do think we have to take these with a little bit of grain of salt, because it's hard to separate the ability to enjoy a coffee each day from all the other things that can come along with that and its benefits on health. But in short, I think some coffee intake is absolutely okay. Your question about, is there the chance for excess fluid intake? That is possible in situations where there is other abnormal health issues present. And so for people who have heart function issues and that the heart is not pumping as well, increased fluid intake can lead to water retention in the body and more strain on the heart. So for people who do have heart problems, we suggest a reduced amount of fluid intake, and along with this, a reduced amount of sodium intake as well, because that avoids the buildup of fluid. There is also certain conditions of the hormone system or the endocrine system that can lead to retention of water in the body. And all of our bodies keep water and salt in balance based on signals related to the sodium levels in the blood. So there are groups of people who have low sodium levels in the blood that can actually be worsened by excess fluid intake, but this is very infrequent and rare. So unless you've heard of that from your myeloma physician or your family doctor or kidney doctor, then usually you won't run into trouble with excess fluid intake. I do think aiming for this 2 up to 3 liter ballpark is generally fine for most individuals, and I think for most of us who are on sort of that say 160 to 200 pound range, then aiming towards that 2 liters of fluid intake is enough to avoid dehydration. It's not enough to sort of keep you going to the bathroom all day kind of thing.
Dr. Kitchlu, this may go back to one of your earlier charts, I'm not sure, but to what extent can the kidney heal itself? And I guess that relates to the damage. But if you could talk a bit more about that and when it cannot, and not so much about the factors that are going to make it worse, but if everything is improved and if you're getting the proper myeloma treatment, can it heal itself?
Yes, great question, Patrick. I'd say, so fortunately, in many circumstances, the kidney can recover with correct myeloma treatment, although we do have a hard time predicting whether kidney function will recover fully and where it will land. And what I'd say is with myeloma treatment, we get at the source of damage to the kidneys, which is the production of abnormal proteins in the blood that then lead to damage within the kidneys. I think a lot depends on how long the damage has been present, because we know that if damage related to these abnormal proteins has been present for a matter of months or weeks, then the kidney's response to this is to develop fibrosis or scarring, which is not reversible over time. Usually, indicators for this, that the damage has been present for a longer period of time, is if we have a longer series of EGFR blood tests to let us know how long kidney function has been reduced. Also, If we do get a kidney biopsy test, we can look at that piece of the kidney tissue for the amount of scarring, and that can help us predict whether the kidney function is likely to recover. The good news in myeloma is that sometimes people get late recovery, so even after 3 to 6 months, there can be some recovery of kidney function, especially even for folks who are on dialysis. Sometimes we see these late improvements. It's usually the case, though, that if there has been more significant reduced kidney function for that weeks or months period, that the degree of recovery is incomplete. And one of the things that is an active area of research now is trying to predict which people are most likely to have recovery of kidney function. I think a lot related to this also is dependent on age and other medical conditions. So for people who are older, who may have conditions like diabetes or high blood pressure that affect the kidney health independently, those kidneys may be less likely to recover from the effects of myeloma as well.
Are there any other questions? Okay. Dr. Kitchlu, really thank you so much for really a very informative, and as you can see from all the interest in the group, we learned a lot today, and we're very appreciative of you taking the time on a beautiful day like this, having traveled up until yesterday. So thank you so much, and this is a small token of our appreciation from the group. Thank you so much.
So this is so very kind and entirely unnecessary. I just want to say again, it's really a privilege to be able to have the chance to speak to you, and my thanks again to Patrick and the organizing committee for putting together this great venue for us to have communication. So thank you.